Good morning, everyone. I, Dr. Megha, is presenting a case of a spectrum of pathological findings in renal transplant recipients with an asymptomatic slow rise in serum creatinine at a tertiary care center in North India. In patients with stable graft function, creeping creatinine may be suggestive of a sinister underlying etiology. With the use of calcineurin inhibitors in this area, the short-term outcomes after kidney transplantation have improved with a little commensurate improvement in the long-term outcome. Significant proportion of recipients with stable renal function will experience a steady and slow decline in graft function, which will lead to graft loss. There has been no reliable prognostic marker that can predict the graft survival, and therefore serum creatinine is used for the assessment of graft function. Though in urine analysis, even proteinuria is a feature that can suggest graft outcome, but it has not been included in the study. Increased serum creatinine level remain the prompt for biopsy and treatment, and therefore we should have a high level of suspicion for acute rejection and a low threshold for obtaining renal allograft biopsy. This will also help in establishing the non-immunological cause of graft loss, and we can treat accordingly. And therefore, it will also prevent us from unnecessary intensification of the immunosuppression when rejection is not present, as calcineurin inhibitor in long term will also lead to allograft nephropathy. Histopathological diagnosis of chronic allograft dysfunction, if known, will help to prognosticate outcomes of creeping creatinine. Aim and objective of the study is to assess the spectrum of all pathological findings in a renal transplant recipient with a slow rise in serum creatinine who haven't met the criteria for acute allograft dysfunction. Inclusion criteria: in patients who had slow and steady rise in serum creatinine over baseline within 2 months. All those who met the inclusion criteria gave consent and were enrolled. Exclusion criteria: any patient who had an acute rise in serum creatinine more than 25% above baseline, after ruling out the obstructions like hydroureteronephrosis and urethral stricture, acute CNI toxicity which was suggested by high drug levels, and after ruling out the acute bout of infections like UTI and acute gastroenteritis. We have all the renal biopsies were obtained under sono guided using an 18 gauge biopsy needle. We have taken 2 cores and biopsies were analyzed using light microscopy and immunofluorescence. Banff 2017 update was used for scoring the biopsies. It is a hospital-based prospective observational study which was conducted during March 2022 to March 2023. These are the demographic characteristics of the study population, where we have seen that the mean age of the patients was 31.9 years and male to female ratio was 7.6:1. Mean baseline serum creatinine was 1.4 milligram per deciliter, and creatinine at which we have taken the biopsy is 1.7 milligram per deciliter. HLA mismatch, 0 to 1 mismatch was there in 2 patients, 2 to 4 mismatch was there in 22 patients, and 5 to 6 mismatch was there in 14 patients. Time of biopsy after transplantation: 3 months to 12 months, 13 patients were there, 12 months to 24 months, 17 patients, and after 24 months, 8 patients we have taken. All patients have received calcineurin-based triple immunosuppression, out of which 35 were on tacrolimus-based and 3 were cyclosporin-based. This is the histopathological finding in the study population. Chronic active ABMR was present in 23.68%, active ABMR 13%, mixed rejection 18.42%, and tubulointerstitial disease 15.7%. CNI toxicity was there in 5% of the patients. Membranous nephropathy 2%, IgA nephropathy was there in 7% with C3GN in 2%. Also 10% of the cases we have inconclusive biopsies. Renal allograft recipients with creeping creatinine were divided into 2 subgroups based on the pathological findings. which was immunological and non-immunological. Chronic active ABMR was the most common histopathological finding that we have found, followed by the mixed rejection. Tubulointerstitial disease was common. It could be because of either the consequences of the rejection that the patient has faced, or it could be either because of the multiple factors like subclinical infections, drug toxicities that he might have encountered. Chronic CNI toxicities, which was seen in 5% of the patient, is not necessarily dose dependent, and there are other factors like variable pharmacokinetics of the CNIs, which would result in this because it has not coincided with the increase in the drug levels. Glomerular diseases were also present, IgA nephropathy being most common. 10% of the biopsy specimens were inconclusive. Biopsies which were done at the time of creeping creatinine have provided additional data on histopathology. Taken together, chronic active ABMR was the most common, and it is the major risk factor for and a forerunner of late graft dysfunction and graft loss. And this underpins the importance of diagnosing active rejection early to prevent progression to chronic rejection. CNI toxicity is not necessarily dose dependent, IgA nephropathy being the most common glomerular lesion. Biopsies-based studies are probably the best available methodology for estimating the main drivers of slow and steady rise in serum creatinine across the renal transplant population. We were able to gain valuable information regarding etiologies that had led to subclinical graft dysfunction and help in the prognostication of the long-term outcomes.